CT brain in head injury. A head injury occurs because of trauma to the scalp, skull or brain and may be classified as closed, no cut to the skin, or penetrating, skin or bone of the skull is broken. Imaging plays a key role in accurate diagnosis. Head CT is done to assess the nature and severity of injury and determine appropriate treatment. Computed axial tomography was first used at the Atkinson Morley Hospital in London in 1972. CT scans rapidly became the mainstay of the diagnosis of structural brain disease until the advent of magnetic resonance imaging during the late 1980s. CT is superior to MRI in the assessment of head injury. CT scans have a relatively high radiation dose, so should be avoided in pregnancy. Claustrophobia is less of a problem compared with MRI. Skull fractures are categorized as linear or depressed, depending on whether the fracture fragments are depressed below the surface of the skull. Linear fractures are more common. The bone windows must be examined carefully. A skull fracture is most clinically significant if the paranasal sinus or skull base is involved. Fractures must be distinguished from sutures that occur in anatomical locations, sagittal, coronal, lambdoidal, and venous channels. Sutures have undulating margins. Both sutures and venous channels have sclerotic margins. Venous channels have undulating sides. Depressed fractures are characterized by inward displacement of fracture fragments. An epidural hematoma is usually associated with a skull fracture. It often occurs when an impact fractures the calvarium. The fractured bone lacerates a dural artery or a venous sinus. The blood from the ruptured vessel collects between the skull and dura. On CT, the hematoma forms a hyperdense biconvex mass, usually uniformly high density, but may contain hyperdense foci due to active bleeding. Since an epidural hematoma is extradural, it can cross the dural reflections unlike a subdural hematoma. However, an epidural hematoma usually does not cross suture lines where the dura tightly adheres to the adjacent skull. Deceleration and acceleration or rotational forces that tear bridging veins can cause an acute subdural hematoma. The blood collects in the space between the arachnoid matter and the dura mater. The hematoma on CT has the following characteristics. Crescent-shaped. Hyperdense, may contain hyperdense foci due to serum, CSF or active bleeding. Does not cross dural reflections. Subacute subdural hematoma may be difficult to visualize by CT because as the hemorrhage is reabsorbed it becomes isodense to normal gray matter. A subacute subdural hematoma should be suspected when you identify shift of midline structures without an obvious mass. Giving contrast may help in difficult cases because the interface between the hematoma and the adjacent brain usually becomes more obvious due to enhancement of the dura and adjacent vascular structures. Some of the notable characteristics of subacute subdural hematoma are: compressed lateral ventricle, effaced sulci, white matter buckling, thick cortical mantle. Chronic subdural hematoma becomes low density as the hemorrhage is further reabsorbed. It is usually uniformly low density but may be loculated. Rebleeding often occurs and causes mixed density and fluid levels. Cerebral contusions are the most common primary intraaxial injury. They often occur when the brain impacts an osseous ridge or a dural fold. The foci of punctate hemorrhage or edema are located along gyral crests. The common locations are temporal lobe, anterior tip, inferior surface, sylvian region; frontal lobe, anterior pole, inferior surface; dorsolateral midbrain, inferior cerebellum. On CT, cerebral contusion appears as an ill-defined hyperdense area mixed with foci of hemorrhage. Adjacent subarachnoid hemorrhage is common. After 24 to 48 hours, hemorrhagic transformation or coalescence of petechial hemorrhages into a rounded hematoma is common. A subarachnoid hemorrhage occurs with injury of small arteries or veins on the surface of the brain. The ruptured vessel bleeds into the space between the pia and arachnoid matter. The most common cause of subarachnoid hemorrhage is trauma. In the absence of significant trauma, the most common cause of subarachnoid hemorrhage is the rupture of a cerebral aneurysm. When traumatic, subarachnoid hemorrhage occurs most commonly over the cerebral convexities or adjacent to otherwise injured brain, that is, adjacent to a cerebral contusion. If there is a large amount of subarachnoid hemorrhage, particularly in the bacillus distans, the physician should consider whether a ruptured aneurysm led to the subsequent trauma. Cerebral angiography may be needed for further evaluation. On CT, subarachnoid hemorrhage appears as focal high density in sulci and fissures or linear hyperdensity in the cerebral sulci. Again, the most common location of post-traumatic subarachnoid hemorrhage is over the cerebral convexity. This may be the only indication of cerebral injury. Diffuse axonal injury is often referred to as shear injury. It is the most common cause of significant morbidity in CNS trauma. 50% of all primary intraaxial injuries are diffuse axonal injuries. Acceleration, deceleration and rotational forces cause portions of the brain with different densities to move relative to each other, resulting in the deformation and tearing of axons. Immediate loss of consciousness is typical of these injuries. The CT of a patient with diffuse axonal injury may be normal despite the patient's presentation with a profound neurological deficit. With CT, diffuse axonal injury may appear as ill-defined areas of high density or hemorrhage in characteristic locations. The injury occurs in a sequential pattern of locations based on the severity of the trauma. The common locations of diffuse axonal injury are subcortical white matter, posterior limb internal capsule, corpus callosum, dorsolateral midbrain. Traumatic intraventricular hemorrhage is associated with diffuse axonal injury, deep gray matter injury, and brainstem contusion. An isolated intraventricular hemorrhage may be due to rupture of subendymal veins. Thank you.